Welcome to the 171st episode of the 988 Crisis Jam. My name's David Covington. I'm your host for today, and we're going to have our third debate. Vic Armstrong, who has been such an advocate and activist in the space of his work with the American Foundation for Suicide Prevention and his Strong Talk podcast. Vic brought us the idea of a debate on, let's use the word emergency in lieu of crisis care. And we've got the sign for the hotline on the Golden Gate Bridge, which actually uses both of the language of emergency phone and crisis counseling. And I'm going to take Vic on today. We're going to explore this topic as Brian Sims will moderate for us. This is our third debate. You'll recall the first debate, Dave Atkins from Listen and Dr. John Draper from Behavioral Health Link looked at AI should be the future of crisis care. And our audience, the crisis jammers, were really not sure about this topic. We had some strong voices on the definitely no and yes or definitely yes, but most people you see were in the middle. And we moved the audience a little bit to the right with that debate. More people said, yeah, okay, I'm open to hearing more about supporting the crisis call taker, text chat taker with AI, supporting management, et cetera. Our second debate, Detective Sabrina Taylor from CIT International and Professor Jen Stuber from University of Washington looked at mental health should come with a police car. Now, our audience, the crisis jammers, were solidly in the place of definitely no or no, with a very few definitely yeses, and 14% said yes to that to start. We did move the audience just a little bit on that topic. But today, let's throw up the pre-debate survey and get a baseline for the question, or I should say the statement. We should substitute the word emergency for crisis services. Definitely no, don't know, I'm not sure, I want to think about that, or yes, definitely yes. Let's get a good sense. We've got about 70, 80 coming in. We'll let that play out. We're now over, looks like we're almost at 100 responses. Okay, this is going to be fun, Vic. The audience this feels more like the AI debate in terms of the baseline. And we'll get into that topic as we get going today. We should substitute the word emergency for crisis services. We're going to explore that. Always, you can get all of the detail, the new registration process, so that we can have a safe and fun community with Crisis Jam, as well as all the video and materials. Promote 988 with a virtual background. You can do all of that at talk.crisisnow.com. And last week, Jolie Long from the National Board for Certified Counselors talked about the interstate counseling compacts and the opportunity to enhance our workforce. Look, we're always searching for new ideas, new segments, new topics, featured speakers for the Crisis Jam. We've had well over 400. We've not counted since we got to that 400 mark, but we're now on the way to 500 unique speakers as we grow the community, as well as those who participated as presenters. And let us know your ideas. We're always trying to graft those in to the program. For our news for the week, several of us had the privilege to be at the White House for the launch of the National Strategy for Suicide Prevention, which was first debuted back in 2001, revised in 2012, and now again a second revision with a national action plan. And you see the Assistant Secretary. I won't still, we'll have Brandon Johnson talk more about it, but Brian Hepburn, maybe just your quick reflections on the panel with the Surgeon General. That was so inspiring. And you walked in to the meeting with Ashley Judd, Brian.
Yeah, it's the panel was very impressive. I thought that the Surgeon General did a really nice job, similar to David Covington, leading the panel. Ashley Judge, it was very sad, right? Talking about her mother and how difficult it was for the family and how difficult it was for her. It was a very compelling panel. Our own Shelby Rowe was there, and I think it was a very good kickoff to an important national strategy that is going to make a difference over the next few years. So thank you, David.
It was really so inspiring. John Snook, Aloe Black, breaking into song. Was that not inspiring?
It really was. The entire panel was impressive. It was just wild. Such a great event.
And the leadership of SAMHSA, Shelby Rowe in particular, everyone involved with this revision, and the centrality of lived experience was really terrific. I'll do one more. Hannah, what was the highlight for you of this launch at the White House yesterday?
Oh, hi, David. Hope. I mean, I think that was such a core part of the conversation, the hope that we all can inspire, the work that we can all do, and how much impact we can have on our fellow human beings. Shelby was amazing as always, and everyone there just really inspired so much hope, really powerful gathering, and left me inspired to do the work that we need to do from this strategy.
Terrific. Thank you, Hannah. And again, we'll have more from Brandon, but two things. They did include a brief, which had 988 front and center as one of the key areas of focus. And there is a webinar presented by Secretary Becerra. It's today. It's later today. I think it's 5 o'clock on the East Coast, if I remember correctly. But we'll put that information into the chat. If you're not yet joining us for the Crisis Now 3 Summit in Amsterdam, it's not too late. Now, many people are going as part of the Global Leadership Exchange, but you can go to Amsterdam and join us on Friday night, Saturday, and Sunday. We are almost finished with the program, and we have a peer first, peer last. We're building 5 living experience TED Talks into the mix. We have 3 debates. We'll have a debate today. We've got 3 debates going on, a couple of fireside chats, including Dr. John Draper interviewing Monica Johnson on lessons from 988. Vic Armstrong doing a strong talk. We'll do some visionary leadership awards and a tribute to Dr. Jan Mockenstorm. So again, if you haven't yet committed to joining us in Amsterdam, Belina's here with us today. Belina's going to be joining us, a team from SAMHSA, Brian Hepburn, a team from NASMHPD. It's a real great group of crisis leaders from not only America, but from around the world. I mentioned Dr. John Draper. John and I have been working together in the space of working with Richard and others around the National Suicide Prevention Lifeline from its inception back in 2005. And great to work with John directly. Now we have launched a podcast, the 988 podcast with David and John on crisis. We're calling it Lifelines. We've done 4 episodes now, but we had a blast with Kevin Briggs. Now, we're hoping to get him on the Crisis Jam coming up, but Kevin talking about his work doing direct crisis intervention on the Golden Gate Bridge was really an amazing discussion. So that brings us to the Crisis Trivia Hot Seat. And today we have the audience in the seat. Unless, John Snook, would you like to jump in? I see you, you're just right there top front and center for me. Would you like to step into the Crisis Hot Seat today?
Sure.
Well, you know, good sport, John. Thanks so much. The last piece of legislation ever signed by President John F. Kennedy was the Community Mental Health Act of 1963. It envisioned a meaningful life in the open warmth of community for individuals with serious mental illness and developmental disabilities. From the outset, there were 5 pillars, 5 key pillars referenced in the Community Mental Health Act. Which of the following was not one of those five, John? Was it emergency response? Was it inpatient facilities? Was it partial hospitalization? Or no, it wasn't any of those, because all three of those were included, is option D. John, you can phone a friend. You can, and we're going to get the audience response here. Any friends you want to phone while we're looking at the audience poll coming through, John?
I do feel a little embarrassed that I don't have the answer just immediately. I'm going to say C, partial hospitalization.
Yeah. So let me give you the audience feedback, and then you can see if that's your final answer. We're split on this. Emergency response is slightly leading. All three were included. Partial hospitalization is in third place, with inpatient in fourth. I will share a clue that this is from the vault, and we have done this in the Crisis Jam before. I tweaked the answers a little bit, but we have done this before. Anyone want to jump in and share? I'm looking at my screen here. Hannah Wozolowski, we picked on you already today. And John needs a friend on this. Any feedback for John before he goes final answer?
Oh, goodness. I'm with you, John. I'm not sure.
This is
I was going to say emergency response, but I honestly don't know.
Yeah, so it's hard to conceive of that emergency response was thought of from the architecture of the beginning of the Community Mental Health Act. But was it or was it not, John? John's thinking it was, and that's the reason partial hospitalization feels like something that just wouldn't have been in the mix back then.
That was my thinking, but I now am wondering if the conversation today may mean A is right. I think Hannah has convinced me we should go A.
Yeah, so the audience went with A last time we did this question. But there are certainly people here in the audience here remembering that all three were included from the very beginning, and they called them emergency response. They didn't call it crisis. So Vic, there you go, handing you a point right out of the gate. Inpatient was a separate item for them. Partial hospitalization, a separate item. But they saw things like the call, text, chat. Text and chat wasn't a concept yet, but certainly calling, mobile response, crisis stabilization. They saw that from the very beginning, and they called it emergency response back at that beginning. So, John, I would have not known that. Hannah, I wouldn't have known that, except, I mean, none of the three of us, we weren't around in the 60s. None of us were even born yet, were we, John Snook? But the reason I know that is in 2005, John O'Brien and the folks from the other TAC, John, the Technical Assistance Collaborative, Kevin Martone and team, John O'Brien led a team that did this paper, a community-based comprehensive psychiatric crisis response service, back in 2005. And preparing for today's debate, I went back to that it's a terrific paper. And for years, many of us in the crisis space walked around with that under our arms like it was the Bible, the New Testament or something. It's an amazing document. And they go back and talk about the 5 pillars, including that emergency response. Of course, Vic, they refer to it as crisis response, and the language has shifted at this point. So we're going to come back to that topic. But let's set the stage with a quote for the day. The Surgeon General yesterday referenced the E.E. Cummings poem, "I carry your heart with me, I carry it in my heart." And it was really quite an inspiring and heartfelt connection with the work that we all do. Now, he was talking more in the context of human-to-human interactions with folks reaching out to our friends and family and colleagues who might be in pain. But for those of you who were in the pre-show and saw the trailer to The Listener, which will be screened at the Chicago SAMHSA Grantee Conference next week, really a great connection from the Surgeon General referencing, I carry your heart with me, I carry it in my heart. So with that, I'm going to cede my host role to Brian Sims, who's going to lead us moderating the debate today.
All righty, well, thank you, Dave. And already we are preparing for this. I'm Brian Sims. I'm one of the senior medical advisors with NASMHPD, and I am so pleased to be the moderator for this particular debate. Today, the topic, as Dave has already pointed out, is going to be the use of the word emergency in lieu of crisis care. And what we've seen so far is that crisis care has become the standard language. We're going to introduce a new element to it in the debate here. So our debaters today are Victor Armstrong, who's the Vice President for Health Equity and Engagement with the American Federation for Suicide Prevention. And he's also the host of what many of you have seen are his Strong Talk podcast, and he will present on the affirmative. And David Covington, our CEO and President of Recovery Innovations, will also present on the negative. Now, we'll begin our debate today with the affirmative. So Vic, if you'll come on, we'll turn it over to you, and your 5 minutes begins now.
Thank you, Brian. I've often raised the issue that when an individual experiences a medical emergency, we call it an emergency. Yet when someone experiences a mental health emergency, we label it a crisis, which begs the question, is it the individual that's in crisis or our affected system? Our use of crisis language complicates our efforts to achieve equity in behavioral health care. We talk, for example, about a crisis workforce shortage, yet when we attempt to address the issue, we find that even among mental health professionals, advocates, and legislators, we struggle to define who is a crisis worker. Language that sets us apart only serves to increase stigma around mental health. It differentiates between mental health and overall health. And health plans argue that they don't know what crisis services are, and that many labeled as crisis services are not emergent services such as crisis respite and crisis residential. So they argue that they have no obligation to pay, and they claim they don't even know what they will be paying for. Equitable access to all in need within a sustainable system of care requires that these vital services be paid for as healthcare services adequately reimbursed by all insurers. There is no formal federal protection or expectations of payment for crisis services. However, there are expectations related to reimbursement of emergency healthcare services in place through the No Surprises Act and Mental Health Parity Act. No wrongdoer crisis services, as defined in SAMHSA's National Guidelines for Behavioral Health Crisis Care, align with expectations of emergency healthcare services. No wrongdoer crisis services offers the most promising solution to advancing equitable access to care, yet our crisis systems are at risk with limited ability to self-sustain due to a reimbursement system fraught with loopholes, pitfalls that only become more treacherous due to vague and ambiguous terminology like crisis care, impacting both care and caregivers. Failure in our own language to distinguish essential core mental health services as emergency healthcare services has resulted in little to no commercial health plan reimbursement of these services. And many states still do not offer Medicaid reimbursement of these services, a failure that is clearly a violation of federal law if recognized as emergency healthcare services. And while the most successful states offer Medicare reimbursement for care, access largely depends on local tax levies, state general funds, federal block grants, and one-time funds to cover the cost of these healthcare services delivered to individuals with commercial insurance. Adequate healthcare reimbursement would be a game changer and would go far in addressing a public health emergency. For example, I had my friend and resident genius, Paul Galdas, provide a quick analysis of the cost of statewide mobile crisis for the state of West Virginia. The projection was $6.3 million annually. However, If Medicaid is pushed to pay for this emergency health service and reimburse at the cost, remember the state only pays its federal match portion of Medicaid costs. The cost to the state drops to $3 million. If the commercial payers then pay their share as part of parity, and no surprises Act expectations for emergency services, the annual cost to the state drops to $1.4 million. This creates financially sustainable access to vital mental health resources by reducing the cost to the state by 78%. Without realizing health plan payment for these services, access to emergency behavioral health services is fully reliant on local, state, or federal grant funding to survive, whereas emergency services supports parity, increasing the sustainability of mental health services as part of our overall health system. We choose to use alternative language such as crisis to describe care for mental health emergencies. We open the door to accept alternative or even less than care, as well as reimbursement when compared to other emergency healthcare services, largely targeting physical health issues. Embracing language of emergency mental health and substance use care immediately positions these services for wider recognition by those in need and offers a sustainable future through adequate reimbursement of care mandated of all responsible payers through existing federal protections. Emergency healthcare services are widely recognized by those seeking care, and emergency healthcare services are reimbursed by all health plans throughout the nation. My recommendation is to use emergency behavioral health for those services defined in the SAMHSA National Guidelines, analogous to 911, EMS, hospital emergency departments, and also use terms like behavioral health urgent care, which has clarity of meaning and purpose. And perhaps crisis care could be used to describe other non-emergent services that are designed to provide care for individuals with an escalated need to distinguish from longer-term services. For example, crisis residential versus residential.
Vic, I'm going to have to stop you here, sir. I want to give fair time to the other side. And at this point, thank you for that. And I'm going to turn it over for the negative viewpoint with David Covington. And Dave, your time begins now, sir.
A crisis has no schedule. That was actually a comment from a person who has lived experience and was in a focus group almost 20 years ago now, as we were conceiving of the first statewide crisis and access hotline. Their point was that we tend to develop programs that fit around our needs. They specifically said, your programs are open from 8 a.m. to 5 p.m. They're not available on the weekends. But our challenges occur throughout the night, over the weekend. We have this constant challenge of responding and keeping in perfect focus the individuals who are in need, the individual who is going to be utilizing that call, text, chat, or mobile crisis or crisis facility. And the word she used was a crisis. So Vic is hitting on really key issues: payment, reimbursement, equity parity around services. But these are challenges we have as programmers that we've got to address. From the very beginning, the discussion from the Kennedy group in the 60s was that these services had to be in play. And we're going to have to figure out how to make sure these occur. But the state of Arizona funds them to the tune of over $300 million with scale and capacity. The state of Georgia is bringing in a similar amount of funding and support. And they're doing that in language that connects most clearly with those who are in a crisis themselves. Now, what we've learned from the communication and marketing experts is the simplest language is the best language. What's the name of that character on Sesame Street that is the big bird? What is the name of that mailbox character on Blue's Clues? They call them exactly what they are. And it's the most powerful way of getting through to folks. I wear this t-shirt. In fact, people think I must never wash it. I actually have dozens of these because I wear it all the time. And I'm in airports. People come up all the time. And the Suicide and Crisis Lifeline it is clear to people who are in need of what that support is. Now, unintended consequences are always something we've got to be cautious about. And while the parallels to 911 are important, there are also key differences. And Vic, that's clearly cheating, relying on Paul Galdis on my team. But Paul did a great job in his input into the original SAMHSA guidelines of raising this issue that we've got to describe them as emergency services. But let's call them crisis services. And here's why. If you call 911 and it doesn't meet their definition of an emergency, in most states, you've committed a crime. It's punishable with fines or even jail time. We're very thoughtful that emergency services are for clear-cut emergencies. They're going to roll a cop, a fire truck, or an ambulance, and they're going to do that quickly. When you call a crisis line, that engagement that we saw Tessa Thompson so carefully, thoughtfully, slowly engaging, for those of you who were in the pre-show for the trailer, it's a different kind of a thing. Now, let me give you one more example. Sometimes we talk about not calling it crisis for other reasons. There are a host of people, including those of us at Recovery Innovations. For a time, we didn't use the word crisis. We went a different direction because of our focus on recovery and felt like crisis wasn't a recovery-oriented word. But what happened when we did that is we saw a slide in the acuity of those in our programs. More substance use referrals, more self-referrals. This is a picture of Christmas week when we had 5 law enforcement cars lined up serving people at the highest need, because for the last decade, we focused on calling this a crisis center. So I'm with Vic on the importance of bringing commercial payers to the table and focusing on this as emergency services care. But let's be careful that we make this as clear-cut and plain. This 988 Suicide and Crisis Lifeline, that brand is beginning to get out there and be knowledgeable for the public. Let's use straightforward language that they can build off of, and let's continue that growth forward.
Thank you, Dave. Thank you, Vic, for those presentations. Before we move on, and with the time that we're looking at, I was just wondering if you would like to maybe make a 1 minute or so closing statement. And we'll start with Vic. Vic, if you would be so kind, sir.
Perhaps more than any other discipline in healthcare, we in the behavioral health and addiction space know that language matters. And the wrong language can significantly hinder the advancement of our collective efforts to realize positive change. Mental illness has been criminalized for decades, resulting in an unholy alliance between the justice system and the mental health system. This criminal justice system response to mental health emergencies has resulted in jails and prisons acting as the largest mental health treatment facilities in the nation. It has resulted in the introduction to the mental health system for many, especially Black and brown men, being in the back of a police car or an acute care emergency department, neither of which is conducive to good mental health outcomes or in creating good relationship with the mental health system. 50 years ago, the March on Washington and President John F. Kennedy's signing of the Community Mental Health Centers Act marked 2 very important milestones for equality and justice in the United States. Consider the similarities between the fight for racial justice and the fight for the civil rights of Americans living with mental health challenges. Both groups sought relief from segregated, discriminatory, and abusive treatment and hopelessness, often exacerbated by the disproportionate impact of social determinants of health, including racial poverty, joblessness, homelessness, and health disparities. And if we continue to utilize the term crisis because it is familiar to us as a field, despite the fact that emergency behavioral health or mental health or substance use services offer a far clearer path to financial sustainability of equitable access to care that decriminalizes mental illness, it is the most vulnerable among us. who will suffer. We should not, cannot hold onto a term, a word that inhibits our ability to advance equitable care, increases our reliance on tax levies and grants, and continues to result in the disproportionate incarceration of historically marginalized people in need of care. Recognizing these services as emergency mental health and substance use treatment services moves this care into mainstream health care, reduces criminal justice system involvement, and represents a significant move toward parity and access to needed services for anyone, anytime, and anywhere. There is a business case to be made for utilizing the word emergency versus crisis, but the most compelling case is a human.
Thank you.
Thank you.
Thank you, David. And now, David, if you will finish up. with the
Yeah,
closing statement as well.
And thank you, Justin. You know, you're on the same path that I'm trying to lay out. You know, Vic, you've done a great job of fleshing out a vitally important issue of commercial payers, Medicare and Medicaid, that we bring the funding and supports for access to services so people don't have to be involved with law enforcement unnecessarily, don't have to go to the hospital ED, don't have to have services more intrusive than they need. But those Sampson National Guidelines from 2020 lay out two, I think, breakthrough concepts to get us to the anywhere, anyone, anytime you mentioned. The first is the whole argument you've talked about emergency services, but there's a separate key element that is fleshed out there, and that is that the crisis is defined by the individual. Once we start down the path of overly focusing on emergency, we are right back to reinforcing where we're at now, that in too many states and in too many areas around the country, there are gates, blocks to us getting the kind of care. One of the things that Arizona has been so breakthrough with is the crisis is defined by the individual. And there's a core element of crisis care, the call, text, chat, the mobile outreach, and those first 23 hours of temporary observation and treatment, which are available to all 4 million people, not just those on Medicaid, but everyone in the county. Now, we've got work to do to have that funded fairly and equitably by all the payers across the board. But we want to make sure we build from a foundation that people know they can outreach for help regardless of what's going on, and we're going to take them through that. If we lead with the word emergency, we're going to minimize our capability to do that. And that's the reason the 988 Suicide and Crisis Lifeline is the right branding, and we should continue that with the tip of our spear. Brian?
I'm sorry. Okay. Thank you both again for a very spirited debate. I think you all as an audience have your information that you need. We're going to be asking on a post survey, and we'll take a look at the results a little bit later on. But I want to quickly move to our roundtable discussion, because we have the honor of having Representative Tina Orwell with us, who will give us some comments on what you just heard.
Wow, what an incredible discussion and so many great points. You know, I have an amazing district. It's culturally rich. I have a school district with over 140 languages spoken. And I keep hearing from the community their reluctance to reach out to emergency services. They've had bad experiences in the back of a police car, you know, being in an emergency department. And so for me, in the short term, I'd like to stay away from emergency services as we really show that 988 and this new crisis system we're creating, which will be trauma informed, is different than the dispatch of emergency services. Now, I say that, and we're doing co-location with 911, and we need to be partners, but our goal is often to move the calls away. You know, as far as the reimbursement, we're requiring in our state that actually private insurance pay for crisis service. I think the problem is we've watered down that term. We have these mobile crisis teams that take hours to respond. And so we're trying to say, are they rapid response crisis teams? So I think we have work to do, but in the short term, I really hope and side with David that we don't use the term emergency. Thank you.
Wow, and thank you so much for that input. We're now going to turn it over to Dr. Brian Hepburn, our Executive Director here at NASPHPD, for his comments as well. So.
Yeah, thank you, Brian. And yeah, I agree with Representative Tina Orwell that it was an excellent debate. I think Victor, as always, is very compelling. And he's a tough debater, bringing up parity, equity issues, as well as payment issues. And also Paul Galdas, right? So he brought up some big guns there. My experience of working in crisis really started in a psychiatric emergency room. That was many years ago. And that psychiatric emergency room really matches up now with a crisis stabilization program. So I think that given that the field moved in the direction of crisis services, that the current language includes crisis, I was thinking very much about what David was saying, that simple language is the best language, and the unintended consequences of changing the language. So I ended up, even though I was initially leaning with Vic, I ended up going in the direction of David. He almost threw me off when he brought up the tip of the spear. That kind of threw me off a little bit. But otherwise, I think I have to go with David and stick with the current language. Thank you.
And thank you, Brian. And again, my thanks to each and every one of the folks involved in this spirited debate. Thank you, Victor. Thank you, Dave, for just generating this. I've been kind of following the chat box, and there's been comments in there, and they are generally kind of indicative of, I don't know how the post-survey is going to turn out, but I'm really anxious to see how this is going to work out. Thank you, Dr. Hepburn. Thank you, Representative Orwell, for your input as well. We're going to ask a couple of comments from Dr. Belina Shaw.
Yeah, thanks, Brian. That I really appreciate this, and to be true to a government employee, I'm not going to take sides. So because it was a really strong debate on both great orators and very, very, very important points. What does resonate with me. It's just the fluidity of the terms, and that because of the fluidity of the needs, and that at the end of the day, we need to be accessible to all individuals, and really not necessarily at the anchoring on a certain term, but really anchoring on their need. And so I think that this is really important as we move forward, and I'm going to use this as an opportunity to really reiterate something that Vic said. Is that we do need clear definitions. And I think that we are in this space. Part of the reason we're in this space is because we don't have very, very clear, concrete, finite definitions of levels of care within crisis care. So when we talk about emergency care or crisis care, that, as a physician, a lot of what might be discussed could be what I would consider urgent, in the urgent care space, and there's just so much overlap. So at SAMHSA, we have embarked upon, and we're starting to embark upon, a process of clarifying terms and definitions, standards and definitions for crisis care. And really in this framework, it will be one that focuses on multiple levels of care to make sure that we are anchoring on the individual's state of need, thinking about a least restrictive setting, but also not separating ourselves from the people of highest acuity needs, because we know that those people are the ones that are at highest risk of engagement with law enforcement. Those are the ones that are at highest risk of being in the back of that police car or being detained, as opposed to getting behavioral health care in a behavioral health setting. So that is really our direction, is creating those crisis standards and definitions. And then also from there, moving forward to think about how do we put all of these pieces of this framework together in a best practice guidance, and to really build upon what was established in the 2020 guidelines, and continue to think about how in this post-988 world, if you will, that we will will build, grow, and meet everyone where they are and anchor on need as opposed to anchor on terms.
And thank you, Dr. Shaw. And thanks to everyone. You now have a lot of information to kind of work on here. So we are ready to kind of go to our debate number 3 post survey. We'll ask that you vote at this time. And we'll compile and give you results a little bit later on. And while we are transitioning, I want to thank you all for this opportunity to be able to host this debate. And at this juncture, I'm going to turn it back to David to carry it on from here. And thanks again.
And thanks so much, Brian, for moderating. And Vic, Vic is such a leader in this space. And Vic, bringing your experience of systems and your pastoral sort of DNA to this is just so much fun and important to do. And Vic, also, again, how do we find this place where we can have rapid response for people in need, right? That's where you're coming from with calling this emergency. Any final sort of reflections, Vic?
Yeah, I guess my final reflection would be, like with all things, I think that as we think through this, when we think about even things like simple language is best, we need to be sure that we're talking about what's best for the end user, not what's simplest for us, not what's easiest for us to navigate, not what is most familiar to us, but what is going to put that individual experiencing a mental health emergency or crisis, if we choose to call it that, what is going to put them in the best position to receive the care they need, when they need it, where they need it, preferably in the place where they live, work, play, or pray.
Amen. Okay, let's go back to Belina for the SAMHSA update, and then we'll get some comments from Brandon about the national strategy.
So yeah, I am just really excited. I know yesterday was such an awesome day, and I know and David really keyed that up. Just want to introduce my colleague that many of you already know, Brandon Johnson, who is the branch chief extraordinaire, who on day 2 of the job got the call that we're revising the national strategy for suicide prevention, and has done it with grace and grit. And he'll just talk a little bit about that process and what those next steps are.
Thanks, Belina. Thanks for having me on. I'm really excited to be on today of all days, honestly. Yesterday, we launched the 2024 National Strategy for Suicide Prevention and Federal Action Plan. For those who weren't familiar with the process, or just how long of a journey this was, essentially this was about 1 year and 4 months in the making that we took the time to develop a new national strategy. And so it is really an all of government effort. I had the honor and the privilege to co-lead the development of this strategy with Dr. Deb Stone from CDC, which many of you all know. We worked really hard to incorporate voices outside of government as well. This is a different kind of process than in strategies past for how we had to do it, with it being a White House request. But with that, we were able to do a needs assessment and got over 2,000 responses to that. We did listening sessions with folks with lived experience, suicide prevention experts, Action Alliance XCOM. We set up an interagency working group that had 10 federal departments and almost 30 federal agencies working on this and developing this document. But just incredibly excited that we're at this point. If you all are, and I think someone already put it in the chat, but definitely something to take a look at if you haven't done so. It will take you some time. So maybe over the weekend, if you're like, sitting around and like, I want to read the national strategy for suicide prevention, then absolutely go for that. We would love to have you engage with it. There are 4 strategic directions in this national strategy. The first one is community-based suicide prevention. Second is treatment and crisis services. And so again, I think you all, if there was a quick dive that you wanted to do on any section, I would say for this group, strategic direction 2 would be the place to go. Strategic direction 3 is surveillance, quality improvement, and research. And 4 is health equity and suicide prevention. We were really wanting to bring that to the forefront. The issue around health equity and suicide prevention is throughout the document, but we really wanted it to be showcased, not just kind of woven in where it could get lost, but really highlighted as a particular strategic direction. The federal action plan is the first of its kind. So all those agencies that we talked about working with, we asked each of them to come up with at least 3 actions that they could take towards advancing the goals and objectives of the strategy. And with that request, we managed to get over 200 action items from the federal government. I don't know how much involvement or experience you all have with the federal government, but it's hard to get that many commitments on paper out to the public of things that we're going to do, and that really I think showcases the the excitement around doing this, the desire for our federal agencies to be engaged in this work. So really excited about that. So HHS released a press release yesterday. There was a story about the event yesterday. Associated Press did a story about it. It's gotten some traction. So definitely take a look at all of those, read the documents. Yesterday's event went really well. David kind of talked through a lot about what happened yesterday, but just a really exciting event to hear, so many people committed to moving this work forward. And so as folks are reading it, as folks are digesting it, taking some consideration of what it means for you, your work, your communities, all of that, please know that I am always here if there's feedback that you all have on it. I'll put my email in the chat when I get finished wrapping this up. And if there's anything you want to share with me, the project management team, I want to shout out, I don't know if Richard's on, but Richard McKeon, Dr. Richard McKeon was on the project management team on this as well, and was an amazing resource for us. Really helped to craft that section that you all are talking of that strategic direction 2 with crisis services there as well. So I wanted to give him a shout out as well. But again, just a real, major lift to get this done. I'm happy we were able to get it out. Again, we're always here for feedback, and this is really just stage 1. The next is implementation. The next is execution. The next is evaluation. We want to make sure that this is impactful and that this doesn't sit as a federal strategy for suicide prevention, but a national strategy for suicide prevention. So I definitely want to also shout out just all of our agency partners that are around the table today, NASHPD and AFSP and others that I'm sure I'm missing on this call. For folks who don't know, Dr. Hepburn was actually one of my old bosses and directors when I was at the state of Maryland. So always good to see him. So again, I'll put my email in the chat if you all need anything, want to bring something up. If there's something that you want to do, if you want to host an event around it, if you want to find a way to communicate it on a webinar to your to the people that you serve or work with or partners, please let us know. We are here and available to help you all craft that, be a part of it. We would love to get this out on a broader scale. And so with that, David, I'll turn it back over to you.
Wow, Brandon, love that. Love the statement, not a federal response, but a national response. This messy but beautiful marriage between federal and states that we're pursuing together with 988 is a really exciting direction. And the amount of integration of feedback that you're describing, Brandon, terrific. Great work. Great work. Let's go to Brian Hepburn. Brandon was talking about Brian. Let's go to Brandon for the Brian for the states update.
Thank you, David. And yeah, I just want to say very quickly how supportive we at NASHPD are of the effort of SAMHSA under the leadership of Dr. Miriam Delphin-Rittman, Dr. Anita Everett, input of Belina, Dr. Richard McKeon, and I really want to thank Brandon Johnson for all his work. He is somebody who has committed his career to suicide prevention. And as he said, it was so nice to work with him when I was in the state of Maryland, and I'm so proud of the work that he continues to do. It's so impressive. And I just wanted to echo the good words that you said, David, and others have said about the kickoff yesterday. And we look forward to working with Brandon and others to successfully implement these national strategies. So thank you.
Got him here.
Thank you, Karen. Thank you to Brian, and for us the opportunity to continue to highlight the states, not only in the Crisis Jam, but also relative to their work with the model legislation. So let's go to Shelley first from Vibrant.
Thank you, David. So a quick update on Nebraska. Previously, they had a bill, LB 929, which folded and turned into LB 1200, that was passed and signed by the governor last week. This bill requires that the Nebraska Department of Health and Human Services and Public Service Commission to collaborate and develop a statewide standard for dual capabilities of 911 to transfer to 988 and vice versa by January 1st, 2005. It also includes, it adds liability protections for 988 call centers, counselors, and names DHHS as an oversight authority for 988 for the state. So that's it for Nebraska. And I'll kick it over to Stephanie to give a couple of more updates on some states.
Thanks, Shelley. Yeah, a couple more we wanted to highlight. Checking back in Vermont. So this is a fee bill pending. It's sort of uniquely structured, would increase their a universal phone fee that they have to 70 cents and add 988 as one of the allowable uses for that funding. Currently, this bill has made it about halfway through the process. And I should have mentioned the bill number. It's H657. Right now it is sitting in Senate Finance Committee. We're hopeful we'll see it voted out this week. Some of the bill's components are running into a bit of a tough time, but not anything related to the 988 section. So hopefully we'll continue to see that moving. And then checking back in also in Maryland, just a reminder, they have a fee bill that has passed as of a couple weeks ago. Still sitting at the governor's desk, but hopefully we'll see him sign that soon. And another theme in legislation that we have seen, of course, is adding 988 into student ID cards as a way to raise awareness of 988 among children and adolescents. And Maryland also passed a bill to do just that before their session wrapped. And then back to you, David.
Thank you, Shelley. Thank you, Stephanie. Stephanie, quick question. So you're talking about sessions wrapping. We're nearing the end of the cycle. It sounds like. What are NAMI's thoughts over the summer of prepping for our? Will this be the third or now fourth year of working for model legislation?
Yeah, I believe. Yeah, this will be wrapping on the third year. Yeah, there's still a lot of states are definitely looking to the model bill still for that structure and finding it really useful. Happy to see states still looking at the fee funding option, but I think something that changed this past year is seeing also states focus more on the other components of the crisis care continuum and funding mobile crisis and creating more crisis stabilization centers.
A lot of discussion at the White House event, moving from call, text, chat to mobile. And certainly that's the SAMHSA Vision 2025 focused on mobile and also getting to the facility options. In terms of mobile, I think there are 3 more states with planning grants as we move toward building on the 15 states with the enhanced Medicaid options around mobile crisis. Let's bring in Stephanie for our crisis talk of the week.
Hi, David. So I'd like to bring on Ray Love. He's a psychiatric pharmacist and past president of the College of Psychiatric and Neurologic Pharmacists. Ray, you told me that pharmacist's role was quickly expanded during the pandemic. Can you tell me a little bit more about that?
Sure, Stephanie. First of all, I'd like to say hello to everybody. This is a great group. I've been participating for a while, and I'm really amazed at everything I've learned. During the pandemic, we not only had the pandemic crisis, we had a crisis in access because a lot of physicians' offices went to a telemedicine platform. A lot of clinics closed or restricted their hours. And one of the things that happened was a lot of patients with serious mental illness or addiction couldn't get their injectable treatment, whether it was naltrexone for a substance use disorder, or whether it was a long-acting injectable antipsychotic. And one of the places that stayed open was pharmacies, community pharmacies. As a matter of fact, they were one of the main places where our population got COVID vaccines, or where you could get Paxlovid if you became infected with COVID. And the public kind of realized that pharmacists had this opportunity to play an increased role, not only in the COVID emergency, but in maintenance roles in healthcare. And this really led pharmacists to be able to do more to administer maintenance injectable medications, again, such as some of the long-acting antipsychotics, long-acting HIV medications. So all that really happened with this change in attitude as a result of the pandemic.
You also spoke about how psychiatric pharmacists in particular can help fill in the workforce gap for behavioral health. Can you flesh that out a little bit for our audience?
Yeah, Stephanie, I want to make sure that all our participants are aware that there's a subgroup of pharmacists that we call psychiatric pharmacists. These are individuals that have gone on for additional training in behavioral health. They've successfully completed a national certification exam, and they work throughout the behavioral health workforce. You'll find them frequently in inpatient settings as members of inpatient treatment teams. In the VA, they tend to be primary behavioral health practitioners who have prescriptive authority. An increasing number work in clinic environments or in public health, and they tend to focus on managing medication, patient and family education, side effect monitoring, coordination of medicines that have complex requirements like clozapine that we use for the most severe cases of schizophrenia. In behavioral health settings, they also tend to be able to bring added expertise to integrate a patient's physical health problems and medications with their behavioral health treatment. And a role that we're just beginning to discuss is the role of psychiatric pharmacists in crisis care.
Mm-hmm.
I'm currently working with Chuck Browning on a paper that touches on this, but I think we'll see that take place in the future with an increasing role both on medication stabilization and medication transitions from crisis back into community.
Great stuff. Stephanie, thank you for your ongoing work. Raymond, thanks for being in the community and for sharing with us. And please visit Stephanie's Crisis Talk interview this week. Great stuff. So let's look at the results for the debate. The community, this is, again, a lot of us in the middle of this discussion, a little bit more toward the negative on this. But Paul Galdis, quick comment from you, if you can give us like 30 seconds or a minute, because I think the points Vic are trying to push today are vitally important to our success going forward.
Yeah, thanks, David. I think that the issue that always faces us, are these sustainable? And it's hard to think that we want to put anything in the way of decriminalizing mental illness, to getting people connected to care that feels like care. And unfortunately, there's a financial barrier that exists for most communities and states. And overcoming it does mean, whether we use the term emergency behavioral health or crisis, that we get all responsible payers to contribute, so local taxpayers aren't paying for services delivered to people that are actually insured. And so I think that's a lot of what we lean into, David, is let's make sure we're creating a strong foundation so we stop decriminalizing mental illness, connect people to care. And that's part of why I think this movement to go to emergency is so important, is because we want to get payers to do it. It doesn't mean there aren't other ways. I love that Dr. Shaw is really leaning into getting these definitions so we can use those to also have a weapon towards getting to parity and reimbursement. That's my take. Fantastic debate today, though.
Great. If you love debates, we got 3 coming up in Amsterdam. We're going to revisit the police and crisis response, routine engagement or last resort, with an international partner. We've got a new one, peers in high intensity crisis care, critical partner or incompatible roles, and crisis facility pre-admission medical clearance, a prerequisite or a barrier to access. So we'll have more on those. Help us get out the word. We asked for your help in breaking 100,000 views. We're actually about 100,000 views a month on the Moving America's Soul on Suicide. And our audacious goal is to break 1 million views this year. So also join us next week when co-response and safe stations from Maryland and from Mississippi, outreach to communities of color and marginalized people with the CROP program. And thanks so much to Vic Armstrong and Brian Sims and everyone who participated today. Look forward to seeing you next week in the Crisis Jam.